I don't believe that there's like a best sleeping medication for insomnia. It's what works for the individual. But really, I think when you're looking at treatments for insomnia, I think the best treatments are therapies. Because you don't want to get yourself dependent on a medication, and insomnia is really about a fear state of not being able to fall asleep, and so that requires different therapy modalities can be helpful, but CBTI, which is cognitive behavior therapy for insomnia, has a lot of research backing it up on its effectiveness, and of course, sleep hygiene practices as well. So, getting to the root of why you're not sleeping, I think, is more important than looking for a solution with a medication for sleep. Trazodone can be very effective. 50 milligrams is a small dose. So if you're still waking up early in the morning, it's helping you fall asleep. You could add something like magnesium glycinate to help with that slow wave sleep, because hitting the 5-HTA receptors, which is what trazodone does, helps with that slow wave, deep wave sleep. So adding in something like magnesium can enhance that so you stay asleep longer without having to increase the dose. Of course, increasing the dose could be another thing to do to get longer duration, but I'm very conservative when it comes to psychotropic medications. And so therefore, I would look for more of the root cause, strongly suggest therapy, not just consider it, but make sure the patient is in therapy for insomnia and getting to the root cause of that, whether it's biological processes, such as maybe elevated cortisol, maybe it has to do with microbiome dysbiosis, which can certainly lead to issues with sleep, especially overgrowth of candida, for example. Things like thyroid dysfunction, autoimmune conditions, are you having pain, et cetera, trying to get to that root and then trying to resolve the issues related to that to help with sleep versus psychotropic medications, which can lead to debilitating symptoms long term, and even issues with dependence. Daniel Duran, hello. You're a channel member. Welcome. Thank you for becoming a channel member. So, channel members do get priority for questions here on the channel. I forgot to mention that early on. It's channel members, then super chats, and then going by the order. So, thank you so much, Daniel, for being a channel member. You do get priority answers to your questions. And there's also a channel member space where there are lots of videos that I did either live or like presentations that I did for members only that you may find useful. So welcome. If you have any questions, let me know. Tanvir, hi. I am facing emotional blending from last 6 months. What can I do? Are you on an antidepressant? Oftentimes, emotional blunting, when I hear that, I think of someone being on an SSRI long term, and that can certainly lead to emotional blunting. So, what you would want to do is, if that's the case, again, we're talking about reducing doses to help with reducing this type of side effect or reducing this type of reaction. So, when it comes to issues with emotional blunting, like if it's just like a depressant, like if we're talking about, someone who's depressed, maybe you have something called chronic depression, or I think that dysthymia is what they used to call it. That can lead to emotional blunting just from persistent symptom of low mood and depression. So something like anhedonia, you don't feel pleasure in things and things of that nature. So what I would say is with that, if it's chronic depression, if it's issues with emotions in general, again, looking for root causes is what I would be thinking about doing. And instead of adding more medication, because that's what would happen if you're on an SSRI and you're having emotional blunting, they'll add like bupropion or other medications or change medications. Same things with like the tachyphylaxis that she talked about earlier. Like you're just going to add medications, you're going to add different things and switch treatments and then get that label of treatment resistant. So you want to avoid all of that. And you want to look for other ways to treat what your symptoms are and figure out what could be causing it. So someone who has persistent anhedonia, like emotional blunting and those kinds of things, I would say that root causes of that could be multifactorial. Look at your life stressors, look at what's going on in your environment. Of course, seek therapy to figure those things out, see if you can get to the root that way. Biological factors, I think a lot of things like nutrients, your vitamins, things like MTHFR, things like your DRD, your dopamine, receptor genes, your vitamin D receptor genes. All of those things, or how are you absorbing your omega-3s? All of them are very, very important for people to maintain emotional stability. So if you have any of those issues, especially with those nutrients, your folate, your B12, your even magnesium, your vitamin D, those specific nutrients, omega-3s, etc., then you're setting yourself up to have this chronic depression lifelong, and then potentially being on antidepressants long term and getting that label, and causing something like emotional blunting. So if hopefully you're not on medications, and if you're not, then I would be investigating those things. Look at my video on basic labs for mental health. That's a great place to start to get to the root of it. Then I would say, of course, look at going to therapy to figure out like what are the life stressors, what are the factors that are causing this symptom of emotional blunting, and get to the root of that. Because it could be, family relationships, work stressors, it could be past traumas, things that happened in your childhood, etc. So there are multiple reasons that this could be happening. Daniel, hi. Hi, yes, thank you, Ms. Rose. The question is selenium good for thyroid health? And is it okay to supplement with it? What would be a good dose? Yeah, selenium can be good for thyroid health. I wouldn't just take selenium like just to take it. I'm trying to think of dosing because I don't use selenium often. I'd have to look up dosing. Like I usually would use it in like a thyroid supplement. Like Life Extensions has one, Pure Encapsulations has one, like thyroid support type supplement. It'll have like selenium, a little bit of iodine, and zinc, usually, but I can't remember the dosages to recommend off the top of my head. But yes, it can be. And oftentimes, when you see thyroid numbers kind of trending outside of optimal, it is due to some type of mineral deficiency. And so, utilizing these types of supplements can be good for overall thyroid health. But I don't use selenium by itself. I usually use it like in a thyroid support supplement. So I'm sorry, I can't give you a dose specific for selenium. Hello, Nancy Olima. Hello, my son 17 didn't do good with 40 milligrams Latuda, but better with 20 milligrams and some little bumps with his moods for bipolar. Does he needs to stay on it with combinations or complete switch of medicine? 17 years old, didn't do good with 40 milligrams of Latuda, but better with 20. Okay, so you're saying that the less medication of Latuda kind of helped his mood for bipolar, um, or a complete switch. So how good is just Latuda 20 milligrams to control cyclothymic bipolar on a 17-year-old? 20 milligrams is for cyclothymia on with bipolar disorder. That's more of like a low depression state, like they're cycling more into that depressive state, but not like completely like major depressive disorder. So 20 milligrams may be able to help that. It is a low dose of Latuda. It's the starting dose. 60 milligrams, would probably be a better target with bipolar, but when it comes to medications, again, the reason why he didn't tolerate 40 milligrams could be multifactorial. There could be many reasons why he didn't tolerate that. Maybe antipsychotics aren't the medication of choice for him. Maybe he needs mood stabilizers. It's hard to say without like knowing, knowing him and knowing his labs, like, and understanding like what biological factors are involved with his case. Because when I think about bipolar and especially cyclothymia, like this kind of present low mood and then hypomania kind of shifts mostly. Um, Man, that could be a lot of things when I think about it in a biological perspective, not conventional medicine perspective. Again, the things that I mentioned earlier with the basic labs, that's step one. Step two is their trauma, because trauma, especially complex PTSD in childhood and things like that, can look like bipolar, get mislabeled as bipolar, because there's a lot of crossover between it and even like borderline personality disorder that could be mislabeled for someone with complex trauma because of the emotional dysregulation and those types of things that happen. So I'd be thinking about that. And medication wise, because I'm not really keen, especially as a 17-year-old with antipsychotics, yeah, I guess you could kind of consider others if 20 milligrams isn't doing it. But I would look at other options and other treatments besides antipsychotics, maybe mood stabilizers. Wonder how he would do with lithium. And maybe he may not need like pharmaceutical lithium. Maybe he could use lithium orotate, low dose lithium, nutritional lithium could be helpful for him. So thinking about those types of things, other mood stabilizers that I would consider relatively safe, but not safe for everyone, like lamotrigine, for example, would be considered. And like I said, lithium, you could do carbonate, but you do have to monitor thyroid function, kidney function, etc. But some people, especially with cyclothymia, maybe it would only need a small dose of lithium to help to manage that. But first, getting to like the roots and figuring out why he's having these types of symptoms. But 20 milligrams, I mean, if he just started that and he's getting some benefit from it, stay on it. Sometimes 8 to 12 weeks is what's really needed before we start to see results. And a lot of times what I notice too with providers is that they'll give a medicine 4 weeks, and if it doesn't help, they switch to something else, and they didn't really give it the time it needed. So I'd caution you about that too, because that is a path that can lead you to the polypharmacy route, where now you're getting on multiple medications. And, for a 17-year-old, I wouldn't want that for him or for anybody for that matter. But at 17 years old, that's really setting up for something like that for polypharmacy. So maybe just kind of sit here for a little while, see how he responds. Also look at diet. What is he eating? Is he on a standard American diet? If so, stop that. He needs to stop eating things that are have high preservatives, high like hydrogenated oils, trans fats, those types of things, all bad for the brain and brain health. Yeah, if you live in Texas, I don't take insurance, and I'm not really able to see a lot of patients right now privately, because I'm currently working 2 jobs. And I'm actually working, the one I'm working here, I won't be at much longer in Florida. And then I'm going to be working full time at the Taper Clinic, which is focusing on getting patients off of medication. So I won't be in the conventional psychiatric space anymore. I'll be shifting more to getting patients off of medications, and that's going to be through the Taper Clinic. So if you live in Texas, there is a nurse practitioner that I know. She moved from, she lived in Texas. I think she's now in Alabama, but very, very good, very sound core values. And that's Ashley P. Evans. and she has Psych Life Mental Health. It's online. I believe she does take insurance. She's a dear friend of mine, and we've corroborated on several different cases before, and just I really like her philosophy. She is very conservative with medications, and so if you were gonna kind of go a conventional route, I would say look her up. She's not, like I said, going to be in person in Texas, but she still has her Texas license. So it would be telehealth for you in Texas. So, but that could be something to look into. Hi, Daniel. I would try to limit my questions. That's okay. If you have hypomanic symptoms, is that automatically considered bipolar 2? Well, that's a good question. So yeah, hypomania would fall into bipolar 2. But if you have a manic episode, so even if it's just one manic episode and then you go into hypomania, you're still going to be bipolar 1. So so some people start off with bipolar 2 because they only have hypomanic episodes, which last less than a week. Like 4 or 5 days is usually you're a little more, alert at night, you're only maybe getting 4 or 5 hours of sleep, you have this, like, energy, maybe you're talking a little bit more, talking a little faster, you're, have this kinda irritability, edginess to you, maybe feeling a little, anxious. Those types of symptoms would be considered like hypomania. And then mania would be if they last longer than a week, or oftentimes they become more pronounced. Sleep is now 2 hours, but you still feel energized. Now you're talking so much, you're bouncing from one idea to another, you're not making sense to people. You become grandiose, like you can do this, you can do that, you're going to start a business, you're going to spend all your money, you're going to, you start doing all of these risky behaviors. And so if that's the case, if you've had an episode like that, that's mania. So you're going to get that label in conventional medicine, bipolar 1. Then, if you have, then you can fluctuate to hypomania. Then it would be, bipolar 1, current episode, hypomanic. Bipolar 2 would just be hypomania, and then your mood, your whether it's like cyclothymia is like not completely major depression, just kind of like that dysthymic type of depression, like that low kind of mood, right? Or you have a complete major depressive episode, and then you fluctuate in those, from depression to normal. You can have normal periods, right? And then hypomania, maybe back to normal, maybe then depression, and then hypomania, like that. You would never really go into a manic episode. That's bipolar 2. Bipolar 1, you can fluctuate through all three: depression, um, mania, hypomania, and then, of course, euthymia, which is normal mood. Or so I guess it's 4 you would fluctuate through. Our crypto, hello. Hi, I'm 26. I weigh 63 kilograms and I'm 174. Oh, geez. Okay. I'm on the US. I'm thinking centimeters, metric system, kilograms. Oh my gosh. Okay. 63 kilograms. So you're probably what, maybe 130 or so, because it's 2.2 pounds, 174 centimeters. I can't even think about what that would be with feet. But anyway, okay, I barely get any sleep. I was prescribed escitalopram, 10 milligrams, and clonazepam, 0.25 milligrams, and stopped after 40 days. Uh-oh. And I barely sleep 2 to 3 hours a day. Yeah. Um, okay. So 40 days, is that enough to become neuroadapted to escitalopram? Probably not for most people, but clonazepam, yes. So clonazepam, you can develop dependence on that, and that's probably mostly what's going on here, where now you can't sleep. Um, I keep my phone away. My room is pitch dark. However, there's some activity in my subconscious brain. Please help. Okay. So, Hopefully this isn't some kind of like protracted withdrawal with clonazepam and stopping that too abruptly after 40 days. If you were taking it regularly, this could be like some paradoxical effect or some kind of withdrawal effect that could be happening here after abruptly stopping a medication like that. Um, if this was like your baseline and you were using medications and then you didn't want to use them anymore, and now you're back to your baseline. So, what do we do for sleep? So, yeah, sleep hygiene is important, keeping your phone out of your room. Another thing that's important is that if you're laying in bed with your mind, you mentioned like I'm laying there, my thoughts are kind of going or whatnot, you're having anxiety. Getting out of bed would be, one of the things that they would teach you in CBTI. So not staying in bed while you're thinking, because then you train your brain, your body, that bed is for thinking. If you just lay there and you let your mind take over. So you have to get out of bed, retrain your brain so you get out of bed, you sit in the living room, you sit in a chair, maybe start reading a book, maybe do a puzzle, do some kind of low level activity like that, until you start feeling like you get that sleep pressure, that adenosine starts increasing. You start feeling like, okay, I'm ready for sleep. You go back into bed, you sleep. If you're not in bed, if you're not asleep, within 15 minutes, you get up again. So it's going to be a couple of rough nights of doing this until your brain finally gets it that, oh, I get it. Bed is for sleep. So when you get into bed, you actually start, you go to sleep. So, so only using your bed for sleep is important for sleep hygiene. Keeping your phone out of the room is excellent. Because you're not only dealing with EMFs, the electrical magnetic fields of phones and all of that kind of stuff. Now that disrupts your brain waves, but you're also not going to be tempted to get that phone because you can't sleep, and now your blue light and all that kind of stuff and dopamine hits, right? You're not going to sleep with your phone on or being on your phone. So yeah, I like that you're doing those things, but I would kind of go back to those basics and make sure you're not staying in bed thinking, because you don't want to train your brain that bed is for thinking. You need to retrain it that bed is for sleep. And then labs on people with insomnia like this, I like to look at a diurnal cortisol pattern. So that's like a salivary test that you take over time. You get one like first 30 minutes that you wake up, and then another couple hours. So it's like 5 samples that you do over the day. And that helps give us an idea of your cortisol response. So, and if that is dysregulated, it kind of helps guide treatment, and then figuring out why it's dysregulated. Is it stressors from work? Is it stressors from life, relationships, trauma, those kinds of things, and then kind of helping resolve those. And then, of course, looking at those nutrients, basic labs for mental health, and making sure that we don't have any underlying conditions or nutrient deficiencies that we're dealing with that can be preventing you from sleep. Magnesium is a perfect example. Very common for people with insomnia because your stress response is already high. You're basically using a lot of magnesium. Magnesium is one of the key nutrients that's needed for that HPA axis, the hypothalamic pituitary adrenal axis. It steals magnesium from the cells. And so because of that, we have a higher need for magnesium when we're anxious and we're stressed. And so that could be something that could be helpful. Magnesium glycinate is my magnesium of choice for sleep. And anywhere between 400 and 800 milligrams is a good therapeutic dose of that. But you can start small. I like pure encapsulations, magnesium glycinate. They come in 120 milligram capsules, and you can slowly titrate that up to a dose that works for you to see if that could be it. So that is often a cause for a lot of people with insomnia. Zinc could also be it, because zinc, if you're low in zinc, you need zinc to convert serotonin to melatonin. So now we're talking about a whole other mechanism that is dealing with sleep. So if you're low in zinc, you're going to have trouble with sleeping. You're also going to have issues with anxiety because it's a cofactor for serotonin, etc. So yeah, B6 could also be a culprit there. Lots of things to really look into. So I would say look at the video labs for basic labs for mental health. Make sure you've ruled all of those things out, and then consider a diurnal cortisol. That would be good to see what your cortisol awakening response is. Consider things like magnesium, I would say would be good across the board. And then some of those other things may or may not be the issue with you, but can be for some people. Muhammad Faizan, hello. I'm currently on olanzapine and valpuric acid, lamotrigine for my hypomanic condition. Everything's going well, but my energy levels are still low. My doc is thinking to add lorazepam in the treatment. Mm. Okay, that would be a little tricky. Adding in Latuda, which is lorazepam, to olanzapine and valpuric acid and lamotrigine. Now we're talking about two antipsychotics. Yeah, this is not in my heart of hearts, and the way that I look at psychiatry and these treatments and things. I mean, I think for anybody in the conventional space, even if you are just prescribing meds and you're not really looking at the holistic thing, would say that two antipsychotics is sketchy, and it's setting you up for some problems down the road. Okay. You have to be very careful with that. Depakote is really hard on the liver already. So there's that. You're already on a mood stabilizer. I'd be wondering if maybe you're on with your energy levels, that olanzapine would be the one that I would think. So maybe if they want to cross taper you from olanzapine and add in something like lorazepam, that could be something to do here for energy levels if we're talking conventional medicine now. The other thing would be like Vraylar actually is really good for improving energy levels. So maybe something like that. But Vraylar, you have to be very careful because it's known to also induce akathisia, which is too much energy, restlessness, internal. You don't want to have akathisia. So that would be very, very cautious, right? Doing that. So I would not add in an antipsychotic with another antipsychotic. I mean, even Stephen Stalls, who's very conventional, warns on that because there really aren't any studies that say, yeah, golly, adding two antipsychotics are great for people. No, there aren't. Actually, you get more side effects, you get more risk, and you really set yourself up for treatment resistance. So yeah, research doesn't back that up. It is very, I would consider risky to just add in another antipsychotic. But if you're talking about transitioning, I would say that isn't a bad idea of transitioning from olanzapine to lorazepam, because olanzapine could be what's causing your energy levels low, because it is very sedating, and especially if you need high dosages of olanzapine to get benefit for your symptoms, then yeah, you're going to wake up feeling really low energy because it's very, very sedating. So people usually end up with like a hangover kind of feeling, or feeling brain fog and those kinds of symptoms. So I could see maybe transitioning from that to lorazepam could be helpful for you. But again, you've been to my lives you're a regular, so you already know the speech on, check your labs, do all of that, because B vitamin deficiencies is what comes to mind when I think of low energy levels, making sure you're ruling out those root causes as well. Daniel, what can you tell us about Tongkat Ali and boron? Because I know that zinc, magnesium, and boron are also helpful for testosterone production. Yeah, don't have a lot of experience with this with hormones. Hormones are not my strength when it comes to root causes. I refer out for hormones, like modulating hormone therapy. However, I do know Tongkat Ali can be used to boost testosterone directly. And I'm not sure the exact mechanism of action. I just know that it's used often by those who work in the hormone space. Boron, I've heard of that too, increasing testosterone, and I believe it might help with dopamine to an extent. Um, Zinc and magnesium, I could see how those could be helpful, particularly because of their cofactors for both serotonin and dopamine. And the reason I say that could also be useful for testosterone, because there's a relationship between dopamine and testosterone. So if dopamine's low, testosterone's low, etc. Testosterone's low, dopamine's low. So there's that relationship there. So when you boost dopamine, you're going to help boost testosterone as well. So, so zinc and magnesium, that makes sense to me on that. I do know Tonkat Ali is something that is used. I even believe Huberman talked about it. So you may want to look at his podcast that he did on. I think he did one just on hormones or one on testosterone itself, and mentioned Tonkat Ali along with some others. But yeah, it's just not, unfortunately, hormones are not my strength. I'm still learning more about them. And it's very complex. It's not an easy, at least in my opinion, an easy topic to like wrap your head around, because you're dealing with multiple layers, multiple factors, not just mental health when you start messing around with someone's hormones. Oh, yes, hi. Hope you're okay. Yes. I just want to ask that can you take amitriptyline for the rest of your life for IBS and insomnia? Do high doses of omega-3 interfere with neurotransmitters? Okay. First question with amitriptyline. Yes, there are people who can take amitriptyline the rest of their lives and not have problems. And especially for irritable bowel, you're using a small dose, and insomnia, like 25 milligrams, some people even 10 milligrams, maybe 50, so anywhere I'd say between 10 and 50, but 25 would probably be the spot there, um, would be the mid-range, I guess. So yeah, there are people who can, but you have to be cautious with antidepressants in general, because there is always that risk of neuroadaptation and needing more and more of the medication that can occur. So just be alert, be aware of that. If that starts to happen, then consider alternatives for IBS and insomnia, because oftentimes with IBS we're talking about dysbiosis, we're talking about Clostridium markers, which they disrupt dopamine beta hydroxylase, which is breaking down your dopamine. So when someone has overabundance of bacteria in their gut, especially small intestinal, bacterial overgrowth, etc., they're going to be more likely to have this clinical picture of IBS and insomnia or anxiety, because they have too much dopamine that cannot be broken down, and also catecholamines, because it interferes with your COMT. So your catecholamine methyltransferase. So when it comes to that, that's what I think of when I look at someone IBS insomnia. So maybe looking at your gut health, doing an oats test would be really good, because you can look at yeast markers, fungal markers, bacterial markers, and then even look at how is this affecting my dopamine pathways? Is it affecting it? You could see the correlation very clear. Also, are oxalates building up because of yeast markers? I mean, there's just the way that test works, and the way you can kind of put the pieces together, you can really come up with some good individualized solutions for your symptoms that can really help treat this without medication. So I would be thinking of that. I mean, to be honest, I've helped a lot of patients with GI problems, and that had both GI and mental health problems, and didn't need to use psychotropic medications. Because oftentimes the root is the gut. The gut is the root of a lot of issues, not just mental health. The gut is tied to the immune system. 80% of our immune system or more, they say, is in the gut, right? And the lining of that gut. So if you have dysbiosis, you're going to have a impaired immune system, especially if you have now leaky gut and now your immune system's on high alert. You have increased lipopolysaccharide, etc. So though you can be on something like amitriptyline, antidepressant, psychotropic medication long term, is that really the way you want to go? That's what I would be thinking, asking myself. Next question. Do high dose of omegas interfere with neurotransmitters? They don't interfere. High dose of omega-3s actually help. Okay. There's a recent study too that came out not too long ago. I came across it where high dose omega-3, they were using 3,000 to 6,000 milligrams, so 3 to 6 grams, very high dose, omega-3s to treat major depressive disorder, and finding profound results with that. Yeah, it helps lower brain inflammation. Your brain is primarily made up of fat, so it does need fat. That's why the ketogenic diet is really, really good for mental health symptoms. And those with severe mental illness, in fact, are finding benefit from ketogenic diet. Because it likes ketones, it likes fats. Omega-3s are essential fatty acids. Our body needs omega-3s to function and for our brain to function. So if you're low in omega-3s, yes, taking high doses of omega-3s will be amazing for you. Now, another thing about supplements is that people think, oh, I'm going to take omega-3s, and in a couple weeks or a month, I should feel better. Not the case. 3 months with supplements in general. Give it 3 months. It takes a long time to develop deficiencies, number one, and then it takes a while for the body to reestablish that homeostasis, and then for it to make an impact or make a change, right? So 3 months is minimum before reassessing how you feel with these types of nutritional supplemental things. So don't give up. The other mistake that people make is, what is high dose? So they'll take omega-3s and they're only taking 750 milligrams. That's nothing. That's a drop in the bucket. That's good for maybe maintenance if someone's already optimal and they want to maintain, they just want to kind of fine. But if you're trying to treat something like mental health symptoms, you're going to need those high doses. That one study was using 3 to 6 grams. I find benefit with 2 to 3 grams. So 2,000 to 3,000, making sure you have a high EPA, DHA focus, because those are primarily known in studies to help with brain health, mood, mental health symptoms. But yeah, they don't interfere with neurotransmitters, but I would say they assist. They help the brain to function better. They help to make those neural connections better. They help decrease inflammation, which is a primary driver of a lot of mental health symptoms. And I touched on that quite well in the video I did on inflammation and depression, kind of explaining that mechanism of action and how things like omega-3s can be very, very helpful, very powerful. So yeah, I wouldn't say interfere, but assist and help neurotransmitter function, connection, brain overall function, and lowering inflammation. Good questions. Thank you. Faisal Iman Wani, hello. How is pramipexole 0.125 for anhedonic depression treatment resistant? Pramipexole, that's like the one for restless legs. I think it's Mirapex is the brand name. I've never used that for anhedonic depression. Or treatment-resistant depression. And I'm trying to think with mechanism of action, maybe because it's assisting with dopamine. That could be why it's used. So this is not something that I normally use. I've used it. I do prescribe it for patients who have restless legs. Like I've had a couple with restless legs that need it, and most of the time that's because of medication side effects causing the restless legs, but to kind of help mitigate that. But as far as using it for anhedonic depression or treatment-resistant depression, yeah, that is not something that I have ever done. or would advise to do, just because if you've been listening, I like to kind of get to the root cause of what's going on. Why was this person labeled treatment resistant? What happened? Doing those labs. I do have a video about why antidepressants don't work. In that video, I talk about this label of treatment resistant and other things to consider when you are down that path of this treatment resistance. And adding in medication is not one of those paths that I like to take. But I guess I could see how someone in a conventional space with only medicine as their tool, um, or psychotropic medications as their tool, would think that something like pramipexole would help, because of its role in dopamine, is what I would say is probably, the logic behind there, but I can't really speak on it because I don't use it for that. I am taking Prozac from 2 weeks, but no benefit at all. Please tell what should do in this situation. Okay, Prozac for 2 weeks, not enough to judge if the medicine is helping or not. 4 to 8 weeks, that's the window, okay? So, no benefit at all isn't a bad thing. If you're tolerating it, no side effects, give it more time. But also, if you're just kind of dipping your toes into psychotropic medications, maybe before, you kind of go down this path, think about what's my root cause and look at the root causes for mental health. Look at the issues I talk about in those videos. The why antidepressants don't work, the video on basic labs for mental health. Kind of looking at those collectively, they're in the holistic playlist on channel. Could maybe spare you going down this path of psychotropic medications, which for many can lead to harm. Hey, Abdul Rahim Fox, thank you for the super chat. Just want to say thank you for your videos. Thank you for the support for the super chat. I don't have my video in here, do I? Let me see if I do. Oh, I do. I forgot I put it in here. That's my little thing. Okay, there we go. Thank you so much. That's very, very nice. Daniel Duran, thank you, and the team as well for keeping the ball rolling. You guys rock. Thank you. I find that a high dose of omegas gives me heartburn. Oh yeah. Okay, watch the omegas that you're getting. That's the other thing with omegas. Good point. If you're taking high potency omega-3s, you want to make sure you're getting them from a good source, a good reputable company. My favorite high dose omega is Med Omega by Carlson Labs. It is a liquid, it's high potency, but you get in 1 teaspoon, you're getting 2,700 milligrams of high potency omega-3s. And it's coated with natural lemon in it, which helps minimize some of this heartburn and the burping and those kinds of things that can be side effects of high dosing omega-3s. So you don't get the fishy aftertaste or the fish burps and those kinds of things. They also do make the capsules. There's also so Med Omega is the one my first go to, because that's like a medical grade. And then the next one would be Elite Omega-3 by Carlson Labs. So same company in a liquid form. I want to say that might be 2,400 milligrams, but still high potency in liquid. They do make in capsules, but the capsules are big and you're not going to get as much in the capsules, the soft gels, that you would with the 1 teaspoon. So in that case, and because they're so big to swallow, so you may want to be dividing them up, dividing your dose up. So if you're taking, let's say you're taking a supplement of omega-3s and you have to take 4 in order to get that dose of 2 to 3 grams, then I would split it up and do 2 and 2, or even do like 1 with breakfast. And taking it with food too can be very helpful for you. one with breakfast, one with lunch, and then maybe one at dinner, you know what I mean? Or two at dinner or something like that. Or taking it before bed so that you're asleep, you know, while, so these issues aren't, and maybe just taking maybe a couple at night, not the whole dose. So yeah, kind of thinking of those things. Taking it with food can be helpful. Number one is making sure you're getting it from a reputable source. So my favorite, Carlson Labs, my favorite omega-3. I would say my next favorite would be Amare. Amare makes a good omega-3. They're a mental health company that does supplements, and they actually use a lavender oil with their omega-3, which really is subtle, but you need to take a lot of their omega-3s to get like a therapeutic dose. So they're for more like keeping like baseline, but they don't have this side effects of heartburn, and they're sourced well. And then I'd say the other one, Nordic Naturals would be the other one that I know you could get on Amazon. So Carlson Labs and Nordic Naturals you can get on Amazon. Amare is just an exclusive company, so you'd have to like sign up and sign up for their program or whatever, and it's just exclusive from them. But yeah, I would say Carlson Labs and Nordic would be like to consumer, grade would be the ones that those are my go-tos. I have Med Omega in my refrigerator right now. So yeah, so that's what I use and I take every day and it works really well. And I don't have the issues with heartburn that other supplements can give you. So getting a good reputable brand, and then splitting up the dose, especially if you're doing a lot of those soft gels, splitting your doses up and taking it with food could also be one of the keys for you, Daniel, to help reduce that effect. Michael Tao, hello. Your content is so helpful. Diagnosed with GAD 3 years ago. Finally considering medication. Do you feel Boost Bar is effective at all? Seems the safest medication. Thank you. So Boost Bar can be very effective for people with GAD and panic. Relative. So when we're looking at psychotropics and we're talking about safety, it's like all relative, right? Because all of the psychotropic medications can potentially cause harm, and you can find nightmare stories on a medication like Buspirone. I know of a couple off the top of my head. So yes, it would be safer than maybe an SSRI like Paxil, or definitely Effexor or Zoloft or something, you know what I mean? When we're talking about dealing with adverse effects, but also dealing with withdrawal, neuroadaptation, those kinds of things. But not to say that it will not happen or occur with Buspirone, because it can. Okay. It's less, I guess you could say less, risky or happens less incident than your SSRIs, SNRIs, those types of things, because it's a partial agonist. So less incidents, but still can cause issues. But what I would do, okay, before considering, if you've been paying attention here, you might know the answer already. What I would do is look at labs, right? Kind of figure out what your core symptoms are, figure out what's going on there, do that basic lab panel that I talk about in that video on basic labs for mental health. And then depending on other symptoms may add to that based off, your symptoms of your anxiety. And when I talk about symptoms of anxiety, I also ask about gut health. Are you bloated after you eat? Are you constipated? Are you having loose stools? Because that gives you a lot of clues as to a potential root cause. So after kind of gathering that information, then looking at vet labs, figuring out what is causing, is it nutrients? Is it dysbiosis? Is it medical issues, thyroid problems, autoimmune issues? Is it trauma, life stressors, executive, issues, dysfunction, work related, career related, that is boom, therapy, very, very helpful. So we have to really step out of this mindset of, I have anxiety, I need a pill. Instead, think of, I have anxiety. What is causing it? Bring awareness to it. So that's the first step. Figuring out what is what is causing it. Is there a trigger? Is there something you're eating that could be causing it? Because food sensitivities could be a trigger for anxiety. And think of that before going to a medication, because I can tell you this, if you go to a medication and your issue is not related to what that medication is doing, which is really masking symptoms, right? Increasing or dealing with your serotonin for buspirone, right? In that hypothalamus region. So it may turn things down a little bit to give you some relief, but it's masking, right? And if you just do that long term and you still have something brewing underneath, that is a problem. This medication over time will stop working. You're going to need more and more. Meanwhile, whatever's happening in your biology that's creating the issue to begin with, that you're ignoring because you put a Band-Aid on it. If you have to at some point get rid of that medication because it stops working altogether, or you add something else, it's like you set yourself up for not only treatment resistance, but a medication injury, where boom, now the medicine's not working. You're having paradoxical effects. You try to come off. Now you're in protracted withdrawal, and that's a nightmare. So to avoid all of that, getting to the root of it is the best way. I'm telling you guys, really. I know it's more work because in our society, we want the quick fix. We don't want to do the work. We don't want to do the inner work that it takes to look into self and figure out what is actually going on. Why is it this way, right? We don't want to look at lifestyle, because I like my standard American diet. How dare you tell me I can't have my Twix or Twizzlers or whatever your thing is, Doritos or whatever it is, cakes, cookies, right? But really, we have to step out of that as a society, and that's why I really love that Make America Healthy Again logo, and I like the way that our administration is going, not to be political, but that is one part of this movement that I'm really standing for, because we really need to take a look at how we as a society here in the United States of America created a lot of these issues. We have the highest obesity rates than any country, diabetes, depression, mental health, and it just keeps getting worse. If pharmaceuticals helped with these issues and they actually were treating the cause, why is it continuing to skyrocket? So those are the questions we need to be asking ourselves, and those are the things we really need to be stepping into when we have symptoms. Getting into what we're doing in our life. How are we exercising? What are we eating? Those are basics. How are we sleeping? Getting to those first, cleaning that part up, and then looking at labs, getting your blood drawn, seeing what your biology is telling us. That's a great place to start. You don't have to do all the fancy functional tests. You don't have to do an OATS. You don't have to do a GI map. You can tell a lot just by blood markers if you know what you're looking at. Okay. And even if you have a blood test that it looks normal, there's still a story behind it, because I'm telling you, those normal labs are not optimal. They're not really what a functioning person should be at, because they base their labs off of a population that is already metabolically sick. And so they're getting their norms from sick people and not optimally healthy people. So that's why labs are skewed, and that's a whole other soapbox for me, but I won't go down that path. But just basic labs for mental health, you can really narrow in, you can really hone in, analyze them, and figure out pretty closely to what could be going on without going down the rabbit hole of all the other functional tests. But you could get ideas and clues as to maybe targeting which test would be better for you, by that blood work, and saying, man, it really looks like you have some dysbiosis here. maybe a GI map would be good for you, or an oats would be good for you, etc., and going there. So yeah, sorry I went on that soapbox and rant, but I just want to make it clear that when considering medication, first do your homework, okay, and consider the risk versus the benefit. And that's why I say and I emphasize skills before pills, because when you choose medication, I think that when people are choosing medication, they are not weighing in that risk of protracted withdrawal, SSRI withdrawal, paradoxical reaction, treatment resistance, etc. All of those are risks of a medication. So it's not just side effects that's the risk. Side effects are the risk too, and there are many, but it's also what could happen if you're now stuck on it and you need to come off, and all of those things, that factors that could happen. So that's what you really need to be careful with. So buspirone can be effective for many people. It is considered safer than your SSRIs, SNRIs, but get to the root cause of your anxiety first before going to medications. All right. Nancy Alima, thank you for the super chat. Thank you very much. Let's put. Thank you so much. That's very, very nice of you. And we've got another one. Oh my goodness, we're just going to be blowing up this. 1 week off Effexor, Caplyta, sequel, bad ear ringing. Effexor and Caplyta. Did you mean Seroquel? I've been on 15 different psych meds in the last year. I'm doing TMS, currently off all meds for 1 week cold turkey. Oh no. Oh, can anything help the ringing in my ears? It's all day. I can't get rid of it. Was last on Effexor 75 milligrams twice daily, Caplyta 21 at night, and Seroquel 25 at night. And you cold turkeyed all of them. Oh, okay. Man, if I had to guess which one it was, I would say Effexor. That's leading to the tinnitus or the ringing in the ears. But really, cold turkeying off all three of those, if you've been on them long term, is very, very, very risky and can lead to protracted withdrawal. And this ringing of the ears could be the first sign of this. So, typically what we do when we have a person who's been on meds for a while, they cold turkeyed and they start having symptoms. And then when I say we, I'm talking about like in the deprescribing space, people who understand how to deprescribe medications. 6 months on them. Okay, that's long enough to have some symptoms and to whip you off. Okay. So though that's not long-term in years, it's definitely long enough for those medications, especially venlafaxine. So what we would do when we have someone who starts to have some issues like tinnitus, like the ringing in the ears, and we're suspecting this person's setting up for protracted withdrawal, is reinstate. So a little bit. So maybe getting you back on 37.5 of venlafaxine. Wait, if you notice the ringing of the ears is a lot less, then we know, boom, this was the one that caused it, right? Then what you're going to need to do, if that's the case, and 37.5 milligrams kind of fixes this, it lessens, and then like maybe a week in, like it's going away, you're like, oh God, wow, it's gone, right? Then you have to then really hyperbolically taper that, like small micro doses, and taper it off slowly to avoid protracted withdrawal. So though ringing in the ears is not, I wouldn't consider that protracted withdrawal. It is a very common symptom of protracted withdrawal. What is protracted withdrawal? Well, that is when you either stop a medication or you're tapering a medication too fast, and you start getting a lot of neurological symptoms that is very, very, very hard to treat. And it can get to a point, and there's different stages, like mild, moderate, severe. So where you have the ringing of the ears, burning sensations, electrical shocks, palpitations, tachycardia out of nowhere. It ebbs and flows, meaning you get waves of the symptoms and then you get windows of relief. And that can last for quite a long time. They call it protracted because or even some people call it post-acute withdrawal because that came from the addiction world. But like you stop a medicine, it doesn't happen like right away. Sometimes it's weeks or even months for some people that they start noticing these issues, and it can progress. So what we can do in this case, because it's just happening like 1 week off and you're starting to have this is like a clue. Maybe we can stop it before you get into that injury. Because once you're into that injury, it's very, very difficult to then go back. Because then reinstating, once you're in a protracted withdrawal state, doesn't necessarily help and can make it worse. So those are things to consider. Dr. Yosef Witt-During has a lot of videos on protracted withdrawal, and he's that's the Taper Clinic. And if you go on that YouTube, you'll see a lot of stories. If you just type in protracted withdrawal, I bet you his stuff pops up, and also website as well, because he's got information on his website on protracted withdrawal. But yeah, so Effexor was increasing suicidal ideation is why you went off. I understand that for sure, and and a good reason to come off of it, but you always want to come off slowly. So perhaps reinstating at 37.5 won't produce the SI, the suicidal ideation, and you could taper, but it'll help that tinnitus, prevent protracted withdrawal, and then slowly micro taper off. If you're looking for assistance in this and you live in the US, go to taperclinic.com. That's where the experts are that taper patients safely, so we can understand your whole story and figure out, what really could have gone wrong here and prevent you from an injury and get you off your medication safely. But just by what you were talking about, and Effexor being a culprit and very, very common to cause a lot of those neurological type symptoms like the ringing in the ears, I would say that one might be the one that caused this. So yeah, just something to think about. If someone's having ringing in the ears and they're afraid to reinstate or they don't want to reinstate, there are things you can do when it comes to music. And it's basically like training your brain to ignore that sound. So you could do stuff. There's actually, what's it called? Vagus nerve music or something like that channel. Binaural beats channel can also, because it's kind of this low frequency pitch kind of a wave. That's what you want. You want to be tapping into like vagus nerve, low frequency waves. So binaural beats could do it. The one channel vagus nerve music, I think it's called, or something like that, music for vagus nerve, will help because it's going to be targeting in that area, but it'll help to reduce that effect. And it may take time for that to go away completely. Inflammation, it can be driven by that. So I think of things like omega-3s, maybe lithium orotate for brain inflammation could be helpful here. Magnesium glycinate may be helpful, especially if it's triggered by stress. So those are just some ideas to be thinking about that could potentially help with this. But yeah, it's going to be, and then for some people too, they'll say white noise, like kind of in the background, can help you not to focus in on the tinnitus. So yeah, so I'm sorry, Sarah, that you're experiencing this, and I hope that you don't end up in protracted withdrawal, because that can be detrimental, and so I'm hoping that this is not what's going on here. Faisal Manwani, hello. Is dysthymia treatable by medicine? Yeah, dysthymia, so that's like that low level kind of like mood that they don't consider major depression, but it's like this low kind of mood. I think of like Eeyore, Winnie the Pooh. If you guys remember Winnie the Pooh, if you're, as a child growing up, I watched Winnie the Pooh. So I think of Eeyore, the he's always like sad and walking around, and he was like an elephant with his trunk kind of swaying, and he was always just so sad and blue, and he always had the cloud around him. That's like someone who's dysthymic. Yeah, I mean, antidepressants medications can help with this, but we're not going and treating the root. So why is this person always so down, always so low, always in this state of chronic low mood? Again, going to your roots, right? Basic labs for mental health. Trauma, I think of that a lot because that could look like that. Um, Especially childhood trauma, because people with dysthymia, they'll usually say, I've been depressed all of my life. I've been like this all of my life. So that's where we think, okay, childhood trauma, adverse child events, um, then your root causes, so looking at labs for mental health, then lifestyle. What is going on in your lifestyle that could be creating a baseline inflammation that could be making you feel like this low mood, low energy type state. So those are the things I would be looking into. Changing up your diet. What's your exercise regimen? If you don't have one, start walking. Even if it's 10 minutes, 15 minutes, get moving, because that's been shown to really help boost mood, boost energy, lower inflammation, all the things that you need to do when you're in this chronically low state. Cortisol is also one that I think about, which can happen with standard American diet long term because of the issues with glucose dysregulation, where cortisol then becomes high and dysregulated. So your cortisol awakening response may be off. So that would be good to kind of consider or think about. So all of those things, adrenal fatigue could be a root cause here with dysthymia. Those are things I think about when someone has something like dysthymia. It is treatable. It is something that you could find the root cause for, figure out what it is, and treat it. Therapy could also be very helpful for getting to trauma, root cause sources, kind of your pattern of thinking. Why are you always glass half empty? Kind of a thinking, helping you to get out of that mindset. And then biological root causes, like I was mentioning. Those are the things that I would be looking for before even trying to go to medication. Because yeah, though medication can be helpful, things like bupropion, for instance, Wellbutrin, right? Very helpful. Things like Prozac could be helpful for someone with dysthymia, but we're putting a Band-Aid on it while things are going to continue and we're not really treating it. It's a Band-Aid. And then the medicine stops working, you need something else or you need more, and we're missing what's going on underneath this whole time. So definitely consider your root causes first, especially with something like dysthymia. Okay. If depression is caused by dopamine hypofunction, what kind of antidepressant would you recommend? Yeah, the neurotransmitter hypothesis or theories have been debunked, especially with serotonin. But it can it can be, and when I say debunked, I just mean like the population in general, like statistically speaking, there weren't enough people with these deficiencies to say that that's what caused depression overall, right? Because depression is multifactorial. So you could have someone with poor serotonin pathways, poor dopamine pathways, et cetera, but it wasn't enough in their studies to say it was statistical significance to say that this is the root cause of depression or this is the cause for depression. So if someone has dopamine hypofunction, maybe it's because of COMT, Val gene. Maybe it's because MTHFR. Maybe it's because DRD, dopamine receptor gene, DRD2, um, not making enough dopamine. Um, Maybe it has to do with hormones, testosterone dysregulation, for instance. We talked about that, how those two go hand in hand. Um, so that's what I think of as far as looking at the root causes. Then if I'm moving to antidepressant and I'm wanting to target dopamine, Wellbutrin, okay? Because you're going to target dopamine and norepinephrine. So when you inhibit norepinephrine transport in the prefrontal cortex, those transport systems also have a high affinity, meaning they attract and they also help to transport dopamine. So when you inhibit the transport and release of norepinephrine in the prefrontal cortex, you are also going to increase dopamine. So that is why bupropion is, when I think dopamine, we need to give them some supportive dopamine. That's what I think of in conventional medicine, antidepressant. The others may have some downstream effects to improve dopamine. And when I say others, Prozac, Zoloft by sigma 1 receptor binding. Prozac is by 5-HTC antagonism. What's the other one? Oh, Trintellix multimodal. That one also has multiple. That has the 5-HT2C antagonism, as well as doesn't have sigma 1, but I believe it has 5-HT1A partial agonism. But those could potentially increase dopamine as what I would consider downstream effects. So they wouldn't be my top, solutions, but medication-wise, well, hands down, Wellbutrin, because that's going to certainly help with increasing dopamine, with dopamine function. But if you have any of those underlying issues, like I just mentioned, COMT, valval, MTHFR, what was the other one? DRD2, or even vitamin D receptor, because vitamin D is so important with dopamine, VDR issues, micronutrient problems. You want to solve that, right? So how do you do that? Well, you see if those genes are expressing themselves. You get blood work. You figure out, oh, am I low in these certain nutrients, and can I support that? With DRD2, the dopamine pathway itself, if you have issues with producing dopamine, genetically speaking, and it's showing itself, maybe we look at dopamine pathways and we see everything's low, HVA, VMA, it's all low, then I'm thinking, okay, maybe we need to increase some dopamine precursors to help produce a little bit more. Maybe you just have a higher need for things like B6, things like vitamin C can help with dopamine function to a certain extent, and synthesis and breakdown, like the cycling of it. So maybe you need some help there. Like I mentioned, vitamin D, very important in that role, and your B vitamins. So looking at B6, I already mentioned, very, very important. But B9 and B12 have supportive roles in that as well. So kind of looking at that whole picture before even jumping to an antidepressant is what I would be thinking. Abdul Rahim Fox, hello. Thank you for the super chat. Let's go do my super chat. All right. You're on venlafaxine for years and have had SD. I met someone and want off. How do I even begin? I also take olanzapine. I'm trying to think of what SD is. I'm having a brain fart here. Is this social anxiety? SAD is social anxiety, but SD, I'm not sure. Or maybe you're having sexual dysfunction. Maybe that's what it is, because you met someone. Okay. Okay, I think that's what you're talking about. Okay. Usually that's like ED, like erectile dysfunction. So I've never seen it as SD, but I think that's what you're talking about. Some sexual dysfunction going on here. I met someone and want off of it. How do I even begin? I also take olanzapine. So with sexual dysfunction and venlafaxine, that is the culprit, more so than olanzapine. Um, if you want to get off of it, a good place to start as a guide would be the Maudsley Deprescribing Guide here. So this book, I have a link for it in the description, but you can find it on Amazon. I think that link, it should take you to the Amazon link. I think it's like 34, 35, maybe close to $40 or something. But so what that Maudsley Deprescribing Guide does, it gives you a general guide of how to safely get off of antidepressants. Now, it's not meant to be a recipe like you do this, you have to do this, this, and this, because each individual is different, and you may or may not be able to tolerate those percentages. So he has like a fast, what would be considered a fast taper schedule, a moderate, and a slow. But even the slow for some people, especially if you've been on it for years, may be too fast. So understanding in his chapter where he talks about like before he gets into the taper plans, he talks about knowing your risk, figuring out what that score is. If you have a high risk score, you want to start off slow to begin with, right? If you have a low risk score, then you could start in the higher, faster taper plans. But then the other thing he mentions too that is important is tracking your symptoms. So what is your baseline? So kind of figuring out where you are now. What is your baseline on the medication? If you start tapering and you start noticing withdrawal symptoms, what are they? And then when you hold and then you reinstate at a lower dose, how much do those symptoms either become tolerable or minimized? Like say you group those symptoms, say your symptoms are brain zaps, anxiety, sweating or something, night sweats. Okay. And you start tapering and those symptoms start to get worse. That's your clue to stop and slow that percentage down. So maybe you were at, let's say 10%, you're going to go down to, let's say 5. Okay. Then you go back to 5. So those symptoms as a group, maybe they were a 7 or an 8 out of 0 to 10 scale. So you're going to group your symptoms into a scale, 0 to 10. What is the number for tolerability? You want to keep that number below 5 as much as possible, for what you can tolerate, right? So when you lowered that percentage from 10 to 5, if you noticed that those grouping of symptoms are now, you would say, actually now I'm from 7, 8, I'm now down to 5, 6. That's good. So maybe hold for a little bit and then see if you can maintain a 5% reduction. If the symptoms flare up again, then slow it down. Now, you could do what he talks about is like a reduction and hold. Okay, you could do that. You could do micro taper, like taking a little bit off at a time each day. Okay, to a whole total of say 5% for that month or 5% for a 2-week period. So there are different ways of doing it. I would say for someone starting out, doesn't really know the nuances of it, if you're not working with a provider who really understands this, the cut and hold may be better for you because then you can really know what your symptoms are. If you're doing a tapering every day, minute, little by little, the changes are very subtle and it may be hard for you to pick up on that, maybe we're going too fast until it's too late, kind of a thing. So I would say for someone just starting out, figuring out this whole tapering world, I would start very conservative and follow, as far as like, let's do a drop and hold. Let's see what my symptoms are, like a watch and wait approach to understand what you can tolerate. Once you figure out what that percentage is for you and you're kind of in a flow, then maybe you might want to consider doing, where every day you're lowering it. So you're tapering like a micro taper. But inevitably with venlafaxine, what you're going to need to do is get this compounded into liquid. You're going to have to take it twice a day because they don't, obviously, once you compound venlafaxine in liquid, it's no longer extended release. So you're going to have to take it at least twice a day. Um, if you were on really, really, really high doses of venlafaxine, I know some people who've had to take it 3 or 4 times a day to get relief. And that also has to do with how you metabolize it too. But generally speaking, twice a day, get it compounded into liquid, which is going to cost you out of pocket anywhere from $75 to $100 for a month's supply, depending on how much you need, etc. But that's like kind of ballpark. And then working with someone who can order that for you to a compounding pharmacy that you could get it. So that is, really what you do with venlafaxine is you have to really slowly taper it, um, uh, over depending on how long you've been on it. It could take a couple of years to come off. But the one thing is that as you do come off, if this sexual dysfunction is related to venlafaxine, it can start to improve. Now, there is something, the reason I say can is because there's something called post SSRI sexual dysfunction, like where they're saying even after you're off of the medication, you could still have some issues with sexual dysfunction. Now, that is very rare. I haven't seen it in my practice. I work with a lot of patients tapering off of medications and work with a lot of patients who just want to be on medication. And if they have something like sexual dysfunction on one medication and they want to switch to something else, oftentimes that fixes it too. So that could be an option if you're thinking conventional. But if you've been on it for a while, you're kind of noticing like, yeah, antidepressants aren't for me. You want to get off of it, which is what I would say would be the best thing to do. Then you need to hyperbolically taper off slowly so you don't end up, because venlafaxine is one that can cause very, very significant withdrawal symptoms. And so that's why you have to really, really go at this very slow and be careful with it. But you may end up in the end still with some level of sexual dysfunction, and it's just going to take time for that to resolve itself and come back. So yeah, I wish you all the best with that, Abdul. Jake Tratt, hello. Do you do coaching? Yeah, I do have the coaching link on my website where I do coaching, but you may not find times because, like I was mentioning earlier, you might not have been here. I'm kind of working 2 jobs right now, and so my time has been very limited. And I know I've got a few people already kind of on the schedule where they're not able to book for a little bit out. So so yeah, you could always look that up on levelheadedmind.com, and I have my calendar on there, and you can see if there are any times available. I think maybe like Friday mornings might be, and maybe or Monday morning. I'm thinking of just my general schedule now. There might be one time slot there. So if that may work for you or not. But I do mental health coaching. Hopefully when I transition to just one job here, one role, then I'd be able to open up the coaching calendar a little bit more and have a little more flexibility there, which will be February of next year. So yeah, so by February in a couple months here, or less than a couple months now, because we're in the end of December. So yeah, my schedule will open up a little bit more. Oh, yes, hello. Can amitriptyline be combined with lamotrigine for depression? Yes. Yes, it can be. But it's not like what I normally do. It's not what I would advise. And if you've been listening, you know what I'm going to say. So I won't jump on that soapbox again. All right. Irene Neo. Hi, do you have a view on ketamine for PTSD and depression? Oh, you know what? Unfortunately, okay. How do I answer this? Because unfortunately I think I have a bias here in a negative way. Because I've had a lot of people come to me who've used ketamine to try to get off of medications, and it made them worse, quite a bit worse. And I guess because I'm in the space of deprescribing and coming off of medications, I'm seeing that population. So I understand that I have this bias, you know what I mean? Like I'm seeing patients who have been harmed by ketamine because of their issues trying to come off of medications, if that makes sense. So it makes me not a big fan of it. And there are things to you have to worry about with using ketamine for PTSD, especially with that depersonalization, right, component. Now, I have to say this. Two of my patients, I have one right now that she's getting a lozenge, a ketamine lozenge. So this is really low dose ketamine, doing very well. Another patient had tried it and did well, and he was a coaching patient, and so he found that microdosing, and he was doing it through a company. I think it's called Joyous, was the company. And I had another patient before him mention that they were going to try that. Not sure how she's doing, but I know with the gentleman I had coached was using it, did really well to help get him out of like severe depression. But you have to be careful and make sure. I think the key here with psychedelics and things like ketamine is that you're working with a certified provider who understands how to use it, because there are studies out there that when used in a controlled environment, like a therapist who understands like the process and how ketamine works and can guide you in therapy so that you don't get into that depersonalization state or get fearful, because it can at least in the patients that I've seen, like I said, I believe it's because I have this bias, and the patients that I'm seeing have other factors going on. But in those patients that have this history of PTSD and use ketamine, it makes them worse. And I have a feeling it's because not only is it because they're trying to come off of medications like benzodiazepines, which is already triggering the nervous system, right? But they also have this underlying PTSD that they've never dealt with in therapy. And the person who gave them the ketamine wasn't trained in psychedelic like therapy, right? So so doing that, you just have to be very cautious. Make sure that you're doing your homework on the people, the clinic or the place that's doing the ketamine, making sure that they have experience in it. They have a therapist they're working with that can help patients who get into these very uncomfortable places during the treatment. And maybe consider, instead of doing like IV therapy, maybe microdosing, and doing things like that company Joyous I mentioned. I think Mood Bloom is another one, but I don't know too much about them. I've just heard of them. But things like that, like microdosing and having like therapy and people helping guide you through the process, I think would be the safer option. If you're not taking medication but you use THC daily, is what you're saying here. Yeah, I'm not a big fan of marijuana either. And I would say I'm not a big fan of THC, especially more CBD, lots of research on that. Great. But THC leads to worsening of symptoms. Putting a Band-Aid on it right now could lead to worsening depression, worsening panic and anxiety, and even psychosis. So I'd be careful with that. And so, yeah, so I don't know how you would respond to something like ketamine, if that would be something that would even be helpful for you if you already are on THC. I guess it would depend on your history, of PTSD, or if you've had experiences with depersonalization before. Those are things that you would want to consider before thinking of using psychedelics, because it can go wrong for people. I've seen it, I think, more so than other practitioners have seen it, just because of my space and my bias. But it's not something I recommend to patients, ketamine nor THC. It's a big no on THC. Ketamine is kind of like, but it's not something I recommend. Is psilocybin any better for neuroplasticity as compared to ketamine? Not sure yet. That's up for debate. There's research going on with psilocybin right now, that looks promising. So it could be, Daniel, it could be that psilocybin turns out to have more benefits for neuroplasticity as compared to ketamine. We just, at least from what I understand, this all of this research is fairly new, and I haven't dug into it very recently, but I know with psilocybin, there's some promising studies coming out with it, that it can help improve neuroplasticity and be a treatment for depression and those types of things, and working on different pathways of of the brain versus neurotransmitters. So maybe I guess that's up for debate. They would have to do a head-to-head study to really figure that out if psilocybin is better or not. And to my knowledge, I don't believe they have one yet. Hi, Melissa Herrera. My 14-year-old daughter has been suffering a long episode of major depression. Prozac made her more depressed, with she even experienced suicidal ideation. Oh, that's awful. She switched to Zoloft, which had her, so from Prozac to Zoloft. Now she's going to start Lexapro. What are your thoughts? Oh boy. Well, this is unfortunate that she's having this response to SSRIs. It's unfortunately common. So I'm not surprised. And that's why a lot of people stop antidepressants, right? My thoughts. So when someone's not responding to SSRIs like what we would think they should respond, and they start having a lot of this suicidal ideation, these adverse effects, right? It's not helping them. I think of SCLA, is it 1 or 6 or one of those transport genes that you could get tested in a genome test is my favorite genetic test for medications because it gives you a lot of these phenotypes. And what you're kind of looking for is there an effect with SSRIs that's making her have where they're not effective, but you're now increasing risk of these side effects. And so, and that is more common than people think. So Genomind, really, really good report. It's about the same cost that, out of pocket as GeneSight. And some insurances will cover it completely. So if you have a good insurance, you might be lucky. But both of those tests are going to give you kind of an idea is if that's what's happening here, if maybe her genes just can't take SSRIs because of maybe a short allele on the SSRI transport gene. And so she's more prone to side effects of SSRIs. So that could be something that's going on. That would be my first thing I would think about, just because you mentioned being on all of them and kind of having this issue, right? The next question, of course, if you've been listening, I would think of is what is root cause kind of going on? Is she deficient in any nutrients? What is her diet? What are her cofactors? So cofactors for neurotransmitters, do we have support for them? B6, B9, B12, zinc, magnesium. Is there too much copper? Vitamin D, the star, omega-3s, like the other star, the co-star. Like when you think about depression and I think about all these nutrients, those are things that really you should be looking into, because another reason why people don't respond to antidepressants and they don't work is because their brains aren't getting the nutrients that needs to even break down food, B vitamin, things like what they call that methylation, to clear it up and put it into the cycle of how neurotransmitters are produced or made, right? And that's maybe a complex topic, but you break down your, like, say you eat a piece of meat and now you want to break down those amino acids into L-tryptophan, breaking down to serotonin, breaking down to, well, actually, tryptophan breaks down into L-tryptophan, breaks down into TPH1 or 2, and depending on vitamin D, which path it goes down is important, whether it goes to the brain or whether it goes to the gut and creates inflammation. And then you have your 5-HTP, right, which then crosses the blood-brain barrier. So each of those steps requires nutrients for it to happen properly and effectively, and to avoid tryptophan from going into inflammation pathways like quinolinic acid and kynuric acid. Very neurotoxic. Okay. Then you've got your vitamin methylation process that needs to happen. So breaking down of your B vitamins, and your gut microbiome does a lot of this work as well. So that's another factor. But breaking down, like, let's say folate, which a lot of people understand because of MTHFR, you need methyl tetrahydroxyreductase, MTHFR, to break that down. But if you have a SNP in there and it's turned on and you're not able to break it down properly, that instead of it producing, so homocysteine is the byproduct that goes into cysteine, that goes into methionine, that goes into this cycle here, S-adenosylmethionine, to break down and recycle, synthesize your neurotransmitters, right? But if that's not happening properly, it directly goes to homocysteine, and now you get accumulation of homocysteine, which is also very inflammatory, neurotoxic when I think of it mental health wise. There's also cardiovascular risk associated with high homocysteine. But the reason why you get it is because of this error in breaking down Bs. Now, B9 is an important one. That's MTHFR, but then there's MTR, MTRR, so other genes with methylation for the other vitamins, like your B9 and B6, which are important in that particular cycle. But those are all things to be thinking of and considering, for her, as far as like, maybe she doesn't have enough cofactors, and then why doesn't she have enough cofactors, and then trying to support her in that. With those cofactors. Now, do you just blindly start giving all of these nutrients to someone? You can, but if you do it blindly, you can actually make someone worse. You can make them more anxious if you don't know now what is their COMT status, for example. Because if you upregulate methylation cycle and you upregulate these catecholamines and neurotransmitters, but then you can't break them down because of poor COMT, that's a problem. So you have to do it in a logical way. You have to give the body what it needs. There are formulas out there that are like all micronutrients, right? Hearty Nutritionals is one of them. They're daily essential nutrients, right? You take all the essential nutrients that you need to support optimal mental health in, I want to say it's 6 capsules a day. Maybe it's divided up or something like that, and maybe 3 twice a day, or it might be 9 capsules, something like that. But you take all these capsules, giving you all the nutrients that you need for proper brain function, and that can be helpful for many people. But if you have other issues going on genetically, it could, if you're giving yourself too much of something, make things worse, or maybe uptick anxiety or something like that. So yeah, those supplements can be helpful, but used with caution because of other issues that may be going on in someone's genetic profile that you have to consider. So yeah, I would really be looking at gene tests for her. Genomind would be my preferred. GeneSight would be my second. And then look at her biology and see if she has anything, what's expressing. Regarding 14-year-old, she's wanting to do voluntary, go inpatient. How should I go about this? Yeah, I mean, it depends. My daughter ends up in a decent psychiatric ward when I take her for voluntary commitment. Yeah, that's unfortunate. I can't really say because I don't know your area where you are. Just do research. figure out which inpatient program is looking at the whole scope of things, which are few. There aren't a lot of inpatient programs that are looking at the whole scope. Maybe she needs instead intensive outpatient therapy where they're doing like 6 hours of therapy a day, right? And they're doing intensive therapy. They call that IOP. Maybe she needs something like that. There are inpatient programs that are not medication based at all, that are all holistic. They're, of course, not recognized at this time by insurance. And so it's going to be out of pocket cost, so they can be expensive. But maybe something like that could be helpful to get her into a safe environment and work on a lot of these underlying factors. But there are many programs like that out there. And if you just look up like holistic inpatient mental health treatment, you'll probably find a lot of those in your area, or maybe in your maybe other, close areas maybe. And so I would be looking at that. And then if that's not an option, maybe because insurances do recognize intensive outpatient programs that you could, especially if she has trauma or something else going on there too, that focus on those types of underlying root causes. And there are many for teenagers. There's one that's online that's called Charlie Health. It's an intensive outpatient program, but it's online. So she would be doing it from home, but it is a lot, she would need to be kind of self-motivated, I guess you could say, and driven to do that. And maybe if she has you there, if you have the time to be with her to do that, that could also be an option, something like that, which I know they do take insurance, and it would be kind of covered under that. And they could get her hooked up with a therapist doing the one, and basically she would be in therapy for, like I said, 6 hours a day. And they also would include like a family dynamic if that's what's needed, et cetera. So kind of looking at it in that regards, and doing multiple check-ins for safety and things of that nature. So it really depends on why she's wanting inpatient treatment. Like if she's at risk of harm and hurting herself, you do have to weigh that in, because if she's saying I'm suicidal, I want to be an inpatient, she really should be an inpatient. She really needs to be, all eyes on her kind of a thing, and monitored. But the other side to this is that, yeah, when you have her go somewhere, even though it's voluntary versus involuntary, if it's a conventional kind of a place, they're still going to want to be pushing different medications. And usually they don't hold them there long enough to really know what the root causes are or even dig into it. They may just kind of try different medications, and maybe she may end up on a combo of medications for her symptoms. So if that's what you're looking for, then that, maybe what you do get with a conventional inpatient unit. But even with those, I would look at what are their ratings on Google, see what people are saying about them, kind of digging into that a little bit more, looking at forums and asking around in your neighborhood to find out, what place would provide some kind of decent psychiatric care and wouldn't just be heavy on the meds, is what I would say. So it's going to take a little bit of digging and homework on your part, Melissa, but I feel for you, because this is hard, having a young daughter, 14 years old, who's dealing with this. Lisbeth Rodriguez, hello. Wellbutrin is a good choice for anxiety? No, it's not. Because it's increasing your catecholamines, norepinephrine, and dopamine, and that can increase anxiety. So not a good choice for someone who has anxiety. If you have anxiety and depression, and you kind of get that anxiety under control with some therapy or something like that, and then you want to treat the depression with bupropion, you could try it then. Or maybe you have something with the anxiety piece kind of managed. But if you're just trying to treat anxiety, Wellbutrin is not the medication of choice. The treatment of choice, in my opinion, is therapy to work on figuring out your external stressors, recognizing your body's warning signs. Like, is it tension? Is it tightness? Is it clenching? Is it sweating? Is it shaking? Is it heart beating? Because once you figure out that, and you can do that with someone who understands like CBT and skills-based kind of therapy approach to treating anxiety, you can then understand um, potentially what those triggers are, and then learn some skills on how you can modulate that, and even change your thought process about how you're perceiving threats, right? Because anxiety is often produced by fear, threats, unknowns, questions, things like that, catastrophic thinking, for example. So, kind of getting to that root, number one in my book with anxiety, figuring out what those external stresses are, what your triggers are, understanding your body, learning skills to de-escalate. Then biology. Okay, so while you're in therapy, getting the biology right, looking at your nutrients for mental health, like I just discussed several times. So look at basic labs for mental health, and then from there, you start to come up with a comprehensive plan for helping someone treat their anxiety. But Wellbutrin is never my option for anxiety treatment, even if we're in a conventional world, even if I'm in a conventional space. I'm not choosing Wellbutrin. Hi, G. Hi, can someone take half a milligram of clonazepam twice daily for a long time, years, for anxiety and be perfectly fine? Any dangers if you are taking it properly? There are people who can do this. So half a milligram of clonazepam twice a day, long term for anxiety, and it's helping you, you're perfectly fine. Yes. And you're taking it properly, meaning you're not up dosing, you're not needing more, you're not going above your prescription, etc. I've seen people on this I mean, gosh, what, I have an 83-year-old? Is he 83? Yeah. I think he's my oldest patient. I think I have an 80-year-old too. I'm just trying to think. But he had a van for years and years and years and years. You know what I mean? Boom, same dope, boom. And they were trying to take him off of it and put him in withdrawals. But at that time, you have to weigh out risk versus benefit, right? If they're stable on it, it's maintaining their symptoms, it's probably safest to keep you on it. There are risks though, and there are dangers, because the thing with benzodiazepines is that it can go fine for years. Okay, and this is a scenario that I've seen all too often. And so people who are on them years, they get very, very defensive about their benzos, because obviously there's more noise being created about the harm, because there's more people now that benzos have been out for so long coming out with issues, withdrawal, bind, benzo-induced neurological dysfunction, and all of these horrible, horrible things that you wouldn't wish on your worst enemy. Okay, because people would and they kill themselves to get out of this torture, and it's awful. It's awful. Okay, wouldn't wish it on my worst enemy. It's awful. It really is hell on earth. And so, yeah, there are a subset of people who can kind of go long term, but there are also a group of people who can go long term, say 20 years, because I've seen this happen, story after story after story. 20 years I was taking my clonazepam. Then all of a sudden, it stopped working. So we upped the dose and upped the dose. And all of a sudden I built tolerance. And how did I end up on 3 milligrams of clonazepam a day, or 4 milligrams of clonazepam a day, max dosing this medication out? And then paradoxical effects happen. What does that mean? Insomnia, increased anxiety, akathisia, agitation. Oh no, this medicine's now hurting me. So now what does the person do? Panic. I need to get off this medication. It's making me worse. So what do? They try to come off of it quickly, because they look at it as poison, which it is at that point, right? Now they're getting themselves off of it, but they come off of it too fast. Now they're in protracted withdrawal or benzo-induced neurological function, and now it's a problem. Now they seek out help, professional help. And now it's like we're trying to to go backwards and fix it, right? Fix the problem. But it takes, unfortunately, years for many people to safely come off and then start healing and feeling better. I have stories about it. Um, Tomas Starshevsky, Emma Hames are recent stories. Angela Peacock, she's a story about multiple medications, not just benzos. But Emma Hames and Tomas Starshevsky were just benzos, okay? And with them, the effects happened more quickly, these kind of building up. So you may think, oh, well, I'm fine. I've been on it for so many years and I'm cool right now. But that same pattern can happen when you're on it long term. And then for some reason, which I believe there's underlying mechanisms at play because you're masking your anxiety symptoms and underlying mechanisms at play like MTHFR, your B vitamins, B6, B9, B12, pyroluria. I haven't even mentioned pyroluria today. But that's like when you're high in cryptopyrroles and you're depleting your B6 and your zinc. That can create high levels of anxiety and even a misdiagnosis of bipolar because you get so agitated. You're so anxious, you're agitated and irritable. So those types of things, and then your basic nutrients, your magnesium, your vitamin D, your B12, your B9, your zinc, your copper, kind of getting those serum levels, figuring all that out. You want to do all of that first to minimize and figure out like, okay, what is really my anxiety caused from? And are there any external factors? Is there trauma? Is there that, get into therapy? Because the quick fix solution now that you found, which is clonazepam 0.5 milligrams BID, may be helping you now, but it's not a guarantee that it's going to be the solution for the rest of your life. And you may end up like some of these other people. So that's the risk you take. And yes, like I said, there are people who can go lifelong. I've got an 83-year-old and even an 80-year-old, 70-year-olds on these medications doing fine. Right. But there's also, I think, and maybe it's just because of my bias, because I see patients who want to come off meds. I also see a lot more who 10 years, 20 years, they've been on them fine. And then until it's not. And then when it's not, and then you try to backpedal backwards, you can't get out of it. You just dig in your hole. You dig the hole, you dig the hole, you dig the hole. And now it's harder to come out. So those are the things you need to be considering with benzodiazepines overall. So, short-term benefit now for a potential horror story picture later. All right, we'll take another couple questions. I'm not sure how many we have left. Let me see here. Oh, yeah, we have too many left. Okay, so let's do two more. Let's do Sarah Jones' question and then whoever's next after her, and then we'll be done. Okay, Sarah Jones. When suicide repeats over and over in your dreams, when you can't find a reason to go on, what can I do? Oh, yeah, this is very unfortunate, Sarah. Definitely see a therapist for this. Reach out for help. I mean, I'm glad that you're getting this out in the open here. 988 is a crisis line, so you can kind of understand. You'll get a crisis counselor who can talk to you, but they can also direct you into resources in your area, and that might be helpful for Melissa Herrera too. If you're still listening, I didn't mention 988 as a resource, but that could be helpful too to kind of find out in your area what resources are available to you that can help. But certainly it sounds like you're in a space where you're having the dreams are repeating, and then you're mentioning this, you can't find a reason to go on. What can you do? So you're in a place of hopelessness and you don't have, you're feeling helpless. And so you really do need to reach out for help. You need to, contact a professional. So if you don't have someone on dial that you can call, like a therapist or a provider that you're working with, then call 988. That's what you need to do. Okay, next question. And I do feel for Sarah that you're going through this, but it's serious. This is a very serious thing, and you do need to reach out for help. Dead Cat 7. I'm on a Abilify injection, 300 milligrams, and it gives me insomnia. Is mirtazapine best thing to take on top? It's what I was prescribed. Yeah, You can take mirtazapine on top of an injection of Abilify, but this is a common thing with Abilify. And once you have it, once you get it by injection, it's kind of in your system long term. And 300 milligrams is on the lower end of their optimal dose. They ultimately like to get you up to 400 milligrams. So maybe it's not the medication long term for you. So have that discussion with your psychiatrist who's prescribing this, and figure that out. Otherwise, you may end up kind of needing to add more medications in the future on top of this kind of regimen. So think holistically of the basic labs for mental health when it comes to insomnia and things like that, though I believe it's triggered by the Abilify, which is common with Abilify. But look for other things. Magnesium could be helpful, magnesium glycinate. Look for your basic labs for mental health, right? Your vitamin D, your B9, your B12, your zinc, your copper. Look at iron panel. Look at your thyroid function, and those different levels there could be also contributing to this picture. And then what is your diet? If you're eating late at night, that can also be affecting your insomnia. Reducing sugar, added sugar foods, reducing box foods, basically junk foods, getting those out of your life reduces a lot of inflammation and can really help improve circadian rhythm, sleep, and insomnia. But yeah, when you're on a medication and it's creating a side effect, conventional medicine wants to always add more when really it's not the best solution, because we're just, again, masking problems here, which can lead to polypharmacy, which is more medications on top of each other. So though mirtazapine can be very helpful, very effective for insomnia and treating a potential side effect from another medication, is it the right way to go? That's what you need to ask yourself. Is this the path you want to take? And then talk to your providers about it. Look for holistic providers. So another thing, if you guys want providers who understand what I'm talking about here, who understand holistic mental health treatments, integrative treatments for mental health, like really, really understand it. Dr. Greenblatt in Psychiatry Redefined is the guy. He is the pioneer of this stuff. He's been doing it for over 30 years, and he has a training for providers like myself, which I did 2 years ago now, but I'm still in his they call it like maintenance kind of member thing, where I can still be involved and get more education, because there's so much to learn, right? And it's just good to always be on top of the research. But anyway, he's got a list on his website, psychiatryredefined.org, I believe, and then providers. So you click on the providers. These are all the providers who completed, at least did 1 year, completion of his functional program. So that could give you an idea. And it's not, unfortunately, I need to get in his ear about fixing the website, because it's not categorized by state, which would be ideal. So you have to hit Control F and search for your state. So like Control F, and I put FL for Florida because they're abbreviated, if you're in Florida, or NM for New Mexico, or TX for Texas, and you'll get, you can kind of decrease it like that, the list, and it'll kind of go down so that you can find providers in your area and reach out and talk about kind of getting to the root causes of your symptoms. So that's a really good resource. He also has a lot of free education, free webinars you could sign up for. They are geared more towards providers, but you can learn a whole lot of information if you're into learning about this stuff just from his free stuff. I mean, I was kind of maybe stalking for a while his free content, and I got all his books here and everything, and learning. and thought I knew quite a bit until I went into his program and realized I was just surface level, but you could still learn a lot of stuff just by doing the free stuff. I did that for years before I actually went into his program and dug a lot deeper. But yeah, that would be a really good place to find providers in maybe your state or your area that could work with you in the capacity that I'm speaking to, as far as digging into the root cause, figuring out what's actually going on and fixing that. Because ultimately, in my opinion, I'm not conventional medicine, mental health. I'm holistic, whole health. And in my opinion, that's the movement moving forward. That is the way of make America healthy again and making us all healthy again, is really looking at those issues and root causes and fixing them so that we can enjoy overall health and overall mental health, because we are connected, right? Our brain and our body are connected because we have a neck, which is something Dr. Greenblatt always says. So that's it for my live. I'm past time here. You can sign up for my newsletter, levelheadedmind.com, and I will be answering some of these questions here that did not get answered. So make sure you're signed up for that newsletter so I can send answers to those questions out and get your question answered that way. Okay. And also keeping up with what's going on. My articles that I actually have, there's an article on protracted withdrawal that actually Tomas Starchevsky wrote for me. I think that's the most recent article up. So if you want, you can kind of look at that and read that. But I send that out in the newsletter, like, the updates and things like that. So make sure you sign up for the newsletter. Check your spam folder. If you sign up, you're not getting the newsletter because sometimes it ends up there. But as far as next year, I'm not sure if I'm going to keep doing public lives yet. I haven't committed to that just yet. I have to reconfigure what I'm going to be doing moving forward into the new year and come up with my plan. I am going to be still doing the members. So if members are getting one live right now, I'm thinking about maybe adding another live just for members and just doing members only lives moving forward. And it's only $4.99. So that could be something you guys consider moving forward. And as far as public lives, I just haven't committed to that yet moving forward. So I'll have to make another announcement maybe in our community section if that's something I decide to do. But at this point, I'm shifting more to just focusing on the members so that I can, give members a little bit more than just one time a month and figure out what I'm going to do with the member section here on YouTube. So thank you so much for your time. Thank you so much for being here with me today, and have a wonderful Merry Christmas. Happy New Year. Happy holidays to everyone out there. And I look forward to seeing you guys all in the comments section, etc., to my videos, which will start coming out again next year. So take care.